Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 149 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, VPJ, an 86-year-old female patient is rushed to your hospital after having a stroke at a smaller hospital. She has a past medical history significant for hypertension and hyperlipidemia. Currently she takes the following medications, lisinopril and lovastatin. She had a prolonged hospitalization at the outside hospital, where she had a history of Pseudomonas aeruginosa bacteremia and was treated with meropenem. Her pertinent vitals include the fact that she is febrile on arrival. Blood cultures are obtained, and treatment with meropenem infusion is resumed. According to her susceptibility results, the pathogen is susceptible to amikacin with an MIC of 16, resistant to cefepime with an MIC of 32, resistant to ceftazidime with an MIC of 32, resistant to imipenem cilastatin with an MIC equal to or more than 16, resistant to levofloxacin with an MIC equal to or above 8, resistant to meropenem with an MIC of 8, resistant to piperacillin, tazobactam with an MIC equal to or above 128, and susceptible to tobramycin with an MIC of 4. You ask the laboratory to set up additional testing for ceftolozane, tazobactam and ceftazidime, avibactam. Ceftolozane, tazobactam comes back as susceptible with an MIC of 2/4 mcg per milliliter or less, and ceftazidime, avibactam comes back as resistant with an MIC of 16/4 mcg per milliliter or greater. Which IV antibiotic changes listed below would be the most appropriate in this case? Would it be A. Discontinue meropenem, and initiate ceftolozane, tazobactam, or B. Discontinue meropenem, and initiate tobramycin, or C. Continue meropenem, but add amikacin, or would it be D. Continue meropenem monotherapy, but use extended infusion? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Discontinue meropenem, and initiate ceftolozane, tazobactam. The meropenem MIC is 8 mcg per milliliter, which is resistant. However, limited data with respect to high dose and extended infusions suggest that higher dosing regimens can still overcome this MIC. For carbapenem-resistant infections, combination therapy has better outcomes than carbapenem monotherapy. Monotherapy would not be ideal because there are other options that makes answer D wrong. Combination therapy would be better than monotherapy, but the amikacin MIC is high, making the goal peak higher than safe in an 84-year-old who is at risk of AKI. That makes answer C incorrect. Aminoglycoside monotherapy has poorer outcomes than combination therapy. That makes answer B incorrect. In this case, use of ceftolozane, tazobactam could be safer than the combination therapy and would have good activity against Pseudomonas. That makes answer A correct. Ceftolozane, tazobactam has special dosing considerations if used off-label. Let's move to the next question please. And the next question reads, PRA, a 74-year-old male patient presents to your hospital with a past medical history significant for colon cancer after hemicolectomy and chemotherapy. He has been doing well post-surgery and with chemotherapy. He has a chief complaint of becoming lethargic lately, according to his wife. At the oncology clinic, laboratory tests and blood cultures are obtained. PRA's blood cultures return positive for Enterococcus faecium. PRA's susceptibility results are as follows: the pathogen is resistant to ampicillin, with an MIC of above 8, susceptible to linezolid with an MIC equal to 2, resistant to crystalline penicillin G with an MIC of above 8, resistant to vancomycin with an MIC above 16, susceptible to daptomycin with an MIC of 2, and susceptible to gentamicin with an MIC below 500. He is admitted, and a transesophageal echocardiography reveals a small 1 cm vegetation on his mitral valve. So my question to you is, which of the antibiotic regimens listed below and dose would be the most appropriate for PRA now? Would it be A. linezolid 600 mg twice daily and gentamicin 1 mg per kilogram twice daily, or B. linezolid 600 mg IV twice daily, or C. daptomycin 10 mg per kilogram IV once daily, or would it be D. daptomycin 6 mg per kilogram IV once daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. daptomycin 10 mg per kilogram IV once daily. For vancomycin-resistant enterococci, abbreviated as VRE infections, higher daptomycin doses have been associated with improved outcomes. Higher doses are considered 8 to 10 mg per kilogram. That makes answer C correct. Not 6 mg per kilogram, which makes answer D incorrect. Linezolid in answer B is salvage therapy for VRE endocarditis, and this patient is not at salvage yet. Linezolid and gentamicin, answer A, would also be salvage therapy, and evidence is minimal. And the next question reads, KPS, a 67-year-old female patient presents to your accident and emergency department with a chief complaints of nausea, vomiting, and abdominal pain. She has a past medical history significant for uterine cancer after a total abdominal hysterectomy in 2011 with recurrence in 2016, for which she received radiation. A CT scan is done and it shows a pancreatic mass. Her blood cultures return positive for Enterobacter after 9.6 hours. The pathogen is susceptible to amikacin, with an MIC of equal to or less than 2, resistant to ampicillin, sulbactam with an MIC of equal to or more than 32, resistant to cefazolin with an MIC equal to or more than 64, resistant to cefoxitin with an MIC equal to or more than 32, resistant to ceftriaxone with an MIC equal to or more than 64, resistant to ceftazidime with an MIC equal to or more than 64, susceptible dose-dependent with regard to cefepime with an MIC equal to 8, susceptible to meropenem with an MIC equal to or less than 0.025, resistant to piperacillin, tazobactam, with an MIC equal to or more than 128. Resistant to levofloxacin with an MIC equal to or more than 8, susceptible to tobramycin with an MIC equal to or less than 1 and resistant to cotrimoxazole with an MIC equal to or more than 320. So my question to you is, which is most appropriate regarding the susceptibility pattern and potential treatment? Is it A? This is likely an extended-spectrum beta-lactamase, abbreviated as ES/B/L, and cefepime is only safe to use at MICs of 1 mcg per milliliter or less, or B? This is likely an AMP-C, and cefepime monotherapy may be associated with poor outcomes when the MIC is SDD, or C. This is likely an AMP-C, and cefepime monotherapy may be associated with poor outcomes because of lack of stability against the enzyme, or is it D? This is likely an AMP-C, and cefepime is stable to use with no special dosing consideration. I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. This is likely an AMP-C, and cefepime monotherapy may be associated with poor outcomes when the MIC is SDD. Extended spectrum beta-lactamases answer A are usually associated with Escherichia coli and Klebsiella species. Cefepime use for ESBLs, even at low MICs, is not recommended. Enterobacter has high carriage rates for AMP-C, which can show resistance to third-generation cephalosporins, but cefepime maintains stability. However, a cefepime MIC of 8 mcg per milliliter is SDD, and high doses should be used, making answer D incorrect. Cefepime is stable against AMP-C enzymes, making answer C incorrect. For SDD MICs, answer B is correct. Cefepime has been associated with poor outcomes when used alone in infections with higher MICs, but this may be related to dosing. And the next question reads, GCB, a 73-year-old male patient presents to your accident and emergency department with a past medical history significant for cholangiocarcinoma complicated by cholangitis after hepatic duct stenting and placement of biliary drainage catheters. With regards to his social history, he smokes 1 pack per day. He is allergic to ciprofloxacin, and the last time he received it he developed swelling. Some of his pertinent vitals and labs include the following: fever with a body temperature of 102.3 degrees Fahrenheit, chills, leukocytosis with a WBC of 22.99 times 10^3 cells per millimeter cubed. The admitting team is concerned for biliary tract infection. GCB is initiated on piperacillin, tazobactam after blood cultures and brain cultures by interventional radiology are obtained. He continues to have a low-grade fever with a body temperature of 100.4 degrees Fahrenheit. His WBC has not dropped below 16 times 10^3 cells per millimeter cubed. On day 4 his biliary cultures finalize as Escherichia coli with the following susceptibility pattern: susceptible to amikacin, meropenem and levofloxacin, resistant to ampicillin, sulbactam, cefazolin, ceftriaxone, ceftazidime, cefepime, piperacillin, tazobactam, tobramycin and cotrimoxazole. So my question to you is, which of the courses of action listed below would be the most appropriate in GCB's treatment? Would it be A. discontinue piperacillin, tazobactam, initiate meropenem, or B. discontinue piperacillin, tazobactam, initiate levofloxacin, or C. discontinue piperacillin, tazobactam, initiate amikacin, or would it be D. continue piperacillin, tazobactam because the patient is somewhat improved? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. discontinue piperacillin, tazobactam, initiate meropenem. Although the patient has somewhat improved, he still has signs of infection. Continuing the same antibiotic, answer D, when the patient has not improved by day 4 and the organism isolated is resistant would be inappropriate. The amikacin MIC of 16 mcg per milliliter, answer C, would cause the peak dosing goal to be 128 to 160 mcg per milliliter because the goal peak is 8 to 10 times the MIC. This is an unsafe goal peak that would expose the patient to AKI. Levofloxacin, answer B, would be possible in this patient, but he has a ciprofloxacin allergy. Because this appears to be an ESBL, meropenem would be the drug of choice in this susceptibility pattern. That makes answer A correct. And the next question reads, GCB recovered well and the ID physician discharged him on a 5-day course of meropenem for ESBL Escherichia coli which was isolated from the drain culture. 7 days after completing meropenem, he presents back to the accident and emergency department, with a chief complaint of bloody output from his biliary drain, fever, and chills. Blood cultures are obtained, and meropenem is initiated. Blood culture grows Escherichia coli with the same susceptibility pattern as the previous isolate except that meropenem now shows resistance with an MIC of 4 mcg per milliliter. So my question to you is, which of the mechanisms listed below is the most likely mechanism of meropenem resistance in GCB's case? Is it A. carbapenem-resistant Enterobacteriaceae, abbreviated as CRE from AMP-C coupled with outer membrane porin loss, or B. CRE from ESBLs, coupled with outer membrane porin loss, or C. CRE from hyperproduction of AMP-C, or is it D. CRE from a carbapenemase? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. CRE from ESBLs, coupled with outer membrane porin loss. Because this is Escherichia coli, there is a very low incidence of AMP-C occurrence which is less than 1%. AMP-C is not the likely mechanism here. That makes answer A incorrect, nor is hyperproduction of AMP-C, which makes answer C incorrect. Typically, with carbapenemase production, the meropenem MIC would be higher than 4 mcg per milliliter, and this would be a short turnaround time for the organism to have acquired genetic material for a carbapenemase. That makes answer D incorrect. This infection is likely seeded from the biliary tract and continuous with the previous infection. Because the patient had a short course of meropenem, the exposure could have caused the organism to adapt and adjust its outer membrane porin, which makes answer B the correct answer. Let's move to the next question please. And the next question reads, SKL, a 57-year-old female patient presents to your hospital, with a past medical history significant for type 2 diabetes mellitus, stage 2 chronic kidney disease, right total hip arthroplasty 2 years ago that was complicated by a MRSA infection after the initial surgery, for which she received 6 weeks of vancomycin 12 months ago. The implant failed, a 2-stage revision, 12 weeks of vancomycin for a repeated MRSA infection and a new implant after completing the vancomycin course. About 6 months ago, she fell and underwent another revision since that surgery. She states that her incision has never fully healed and she adds that occasionally has slimy green purulent discharge. She presents to the hospital with fevers with a body temperature of 102 degrees Fahrenheit to 103 degrees Fahrenheit, chills, night sweats, and redness tracking from her hip. A CT scan reveals that the infection has invaded deeper tissue. The orthopedic surgeon takes her to the operating room for another hip revision and resection of femur because of intraoperative findings of pus in the bone. Pause the video and scrutinize the table which summarizes the operating room culture and sensitivity results for Staphylococcus aureus over the past 1 year. And my question to you is, which treatment and rationale listed below are the most appropriate for SKL's case? Is it A. intravenous cotrimoxazole, for exceptional bone penetration, or B. Linezolid, to avoid the potential for increased glycopeptide and lipopeptide resistance, or C. Daptomycin, because several courses of vancomycin have failed, or is it D. Vancomycin, because this infection is a distinct event from the prior infections? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Daptomycin, because several courses of vancomycin have failed. This patient has had her fourth hip revision in 2 years, with MRSA infections being the root of failure in 2 of the revisions. Although the third revision was done because of injury, the draining infection afterwards suggests that MRSA was never fully cleared from this patient. Whether that is because of biofilm formation, the presence of small colony variants, or HVISA is unknown because none of these can be tested for in the clinical microbiology laboratory. If any of the earlier is expected to be the cause, a change in antimicrobial therapy is warranted. Answer D is incorrect because further use of vancomycin would cause treatment failure for this patient. Answer B would be possible, but the adverse events with linezolid occur with prolonged courses, and this patient might not tolerate 6 weeks of linezolid. Sulfamethoxazole, trimethoprim, which is diluted in 5% dextrose solution, answer A, has limitations in this patient because of a high dextrose load with intravenous administration, bearing in mind the patient has diabetes and potential for acute kidney injury AKI. Remember, the patient has baseline chronic kidney disease, and sulfamethoxazole, trimethoprim is a poor choice for outpatient parenteral antimicrobial therapy due to short stability of the diluted solution for infusion. Of the options, daptomycin has the safety and efficacy to be the next step in a patient who has failed vancomycin. That makes answer C correct. And the next question reads, GEE, a 92-year-old female patient presents to your accident and emergency department from a nursing home, with a chief complaint of a 2-day history of vulvar pain. Her right labia has erythema and induration consistent with an abscess. She has a past medical history significant for obesity, depression, hypertension, coronary artery disease, hyperlipidemia, stage 2 chronic kidney disease, and anemia. She is allergic to penicillin, and the last time she received a penicillin, she developed hives. She is also allergic to sulfur drugs. She developed a rash the last time she received a sulfonamide. Her current meds include metoprolol, duloxetine, aspirin, and lisinopril. She is transferred to the operating room, and your obstetrics, gynecology team drains most of the abscess in the operating room, noting a size of 5 cm wide, 5 cm deep, and 10 cm long. Abscess cultures are sent, and vancomycin is initiated. Pause the video and scrutinize the table which summarizes the culture results with regard to MRSA, which is resistant to clindamycin, oxacillin, penicillin, and tetracycline. It is susceptible to cotrimoxazole, vancomycin, daptomycin, and linezolid. The patient slowly improves after 3 days of vancomycin but is not doing quite as well as the team would like. Because she is returning to the nursing home, they can discharge her today to continue IV antibiotics, if needed. So my question to you is, which treatment recommendation would be best? Would it be A. daptomycin for 10 days, or B. dalbavancin for 14 days, or C. vancomycin for 10 days, or would it be D. linezolid for 10 days? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. dalbavancin for 14 days. This patient has a large abscess and slow improvement, and she is a candidate for continuing intravenous therapy. One of the most common adverse events with vancomycin therapy is the development of AKI, and this patient already has several risk factors for AKI, which include age, hypertension, and chronic kidney disease. The morbidity, mortality of AKI in a patient like this could be high. Treatment with vancomycin, answer C, would not be ideal in this candidate. She takes duloxetine, a serotonin norepinephrine reuptake inhibitor, which carries the risk of serotonin syndrome, for which age can also be a contributing factor. Thus, linezolid, answer D, would not be ideal. Because of limitations on cost per day, very few nursing homes will accept a patient taking daptomycin because it can cost more than they are paid for the day. Thus, daptomycin, answer A, would not be the best choice. Dalbavancin, answer B, can be given in an outpatient clinic after hospital discharge and before nursing home readmission. Adverse events are low, and no further doses are needed, hence, the patient will not need a line placed. Let's move to the next question, please. And the next question reads, KEM, a 59-year-old female patient presents to your accident and emergency with a chief complaint of diarrhea. She has had 10 to 15 loose stools per day, and coagulopathy secondary to warfarin. She has a past medical history significant for chronic pancreatitis complicated by portal and splenic vein thrombosis. She was recently hospitalized, during which she had an aborted Whipple procedure and a portal, splenic vein thrombosis lysis. She also acquired a Clostridioides difficile infection. An abdominal CT is done and it shows a recurrence of portal vein thrombosis. She is admitted to the medical intensive care unit for observation and INR reversal. On day 4, KEM develops a low-grade fever with a body temperature of 99.9 degrees Fahrenheit. The team orders urine and blood cultures, initiate vancomycin and cefepime. The result in both urine and blood is as follows: the Enterococcus fischum is resistant to ampicillin, penicillin and vancomycin. It is susceptible to linezolid, daptomycin and gentamicin. On day 5, E. faecium is cultured. On day 6, E. faecium is cultured. The first culture shows vancomycin-resistant enterococci, abbreviated as VRE. The patient is changed from vancomycin to daptomycin 6 mg per kilogram. Repeat cultures still fail to clear. On day 9, Enterococcus fischum is cultured. Repeat susceptibilities show same pattern, and the daptomycin dose is increased to 10 mg per kilogram. The primary team wants to avoid linezolid because of thrombocytopenia. On day 10, Enterococcus fischum is grown. On day 12, Enterococcus faecium is grown. Pause the video and scrutinize the table with the reported results. The Enterococcus fischum is resistant to ampicillin, penicillin, and vancomycin. It is susceptible to linezolid, daptomycin, gentamicin and tigecycline. Daptomycin MIC is confirmed with an E-test, whose reading is MIC 2 mcg per milliliter. KEM's blood cultures continue to grow vancomycin-resistant enterococci, VRE. Infectious diseases is consulted on day 12 of bacteremia, day 16 of hospitalization. So my question to you is, which of the antibiotics listed below would the infectious diseases consult service best recommend adding to daptomycin in KEM's clinical scenario? Would it be A. tigecycline, or B. ceftaroline, or C. gentamicin, or would it be D. linezolid? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. ceftaroline. This patient has a refractory bacteremia, despite appropriate treatment and cultures that say the organism is susceptible. The daptomycin MIC has shown an increase by automated testing machine but has repeatedly been 2 mcg per milliliter on E-test. Case series have shown that refractory VRE bacteremia responds to combination therapy, and daptomycin susceptibility can be restored with combination therapy. Adding linezolid, answer D, has not been shown to be synergistic with daptomycin, or any antibiotic, and the primary team wants to avoid it. Tigecycline, answer A, can be used for VRE, but because this is a bacteremia, its low serum concentrations do not make it a good choice. Gentamicin, answer C, has been looked at for synergy with daptomycin but lacks sufficient in vitro data to support its use. Daptomycin plus ceftaroline, answer B, has been used in MRSA infections and some Enterococcus cases. Daptomycin also has in vitro evidence to support its use because the combination can show synergy as well as restore daptomycin susceptibility in daptomycin non-susceptible isolates. And the next question reads, LKS, a 75-year-old female patient is brought to your accident and emergency department by her family after noting increased lethargy and a temperature of 102 degrees Fahrenheit at home. She has a past medical history significant for shortgut syndrome and she is receiving chronic home total parenteral nutrition, hypertension, atrial fibrillation, type 2 diabetes mellitus, and stage 3 chronic kidney disease. She also has a history of Candida parasilosis candidemia, for which she received an extended course of micafungin within the past 6 months. Her pertinent vitals and labs in the accident and emergency department include a body temperature of 101.3 degrees Fahrenheit, a WBC of 16.2 times 10 power 3 cells per millimeter cubed, a blood pressure of 80 systolic 42 diastolic. She has a single lumen PICC and poor venous access. She had a femoral line placed and was moved to the medical intensive care unit. Fluid resuscitation, norepinephrine and broad-spectrum antibiotics were initiated. Blood cultures on admission showed yeast on gram stain, so the primary team initiated micafungin. Blood cultures are as follows: on day 1 Candida glabrata is grown. On day 2 Candida glabrata is grown. On day 5 Candida glabrata is grown. The PICC is removed and recited. On day 6 Candida glabrata is grown. The femoral line is also removed. On day 8 Candida glabrata is grown. On day 10 Candida glabrata is grown. Because of persistently positive cultures, the team sends isolates to a referenced laboratory for susceptibility testing. However, to date, echinocandin resistance has not been identified at this institution. So my question to you is, while waiting on susceptibility results, which would be the most appropriate next step in the LKS's treatment? Would it be A. Change micafungin to amphotericin B, or B. Change micafungin to high-dose fluconazole, or C. Continue micafungin, but increase the dose to 200 mg daily, or would it be D. Continue micafungin? Continued candidemia is likely because of the failure of source control. I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Change micafungin to amphotericin B. Sending the isolate for susceptibility testing suggests that this hospital does not already have susceptibility testing, which may explain why the hospital team has not identified resistance before. Although there has been some evidence for an increased dose in critically ill patients, this patient, although complicated, does not meet the definition of critically ill patients. Without knowing the MIC distribution in the hospital, increasing the dose, answer C, would be futile. Given the high rates of fluconazole resistance, a change to fluconazole would not be wise, answer B, even when dosed appropriately. A failure of source control is possible in this patient, however. She had a PICC line replaced while candidemic and has access difficulties that make a line holiday unlikely, making answer D incorrect. The main risk factor that has been identified for echinocandin resistance is prior exposure to echinocandins. This patient has had micafungin recently. A change to amphotericin B, answer A, though risky for chronic kidney disease, would be appropriate because this could be resistant candida. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 150.